Okay, good evening, everybody. Welcome to tonight's webinar. So we have a great topic for you tonight. We've looked at a lot of the feedback we've gotten from previous webinars, and people want to talk about rotator cuffs. So tonight, we have a great faculty for you, two very good friends of mine, and we're going to talk about failed rotator cuff repairs, revision repair versus subacromial balloon spacer. There we go. So I'll be your moderator. On our faculty side, we have Dr. Brent Ponce. He is a good friend and scholar. He is the chair of the research at the Houston Foundation at the Houston Clinic in Columbus, Georgia. So he'll be helping us out tonight. So he's going to be working in the background. If you have questions, fire them into the Q&A box. That's the proper route to get them to Dr. Ponce. Some of the ones he'll answer straight away. Other ones he may interrupt us during the talk and we'll talk about it. And some of them he'll save towards the end of the talk. We'll have a good 5 to 10 minutes after each talk to go over any questions, answer any things that pop up. And so we're gonna try and keep this pretty light, like a dialogue. So it's more of a conversation. So please feel free, any questions you have, put them into that Q&A box and we will get to them. We also are joined by Dr. David Weinstein. So he is the Associate Clinical Professor at the University of Colorado in Colorado Springs. He is with the Colorado Center of Orthopedic Excellence. Great friend. Dave and I have done a lot of these webinars and talks together. So it's a pleasure and an honor to have him with us. Fantastic shoulder surgeon in the Colorado Springs area. So these are our disclosures. These are also online if you need to look at them. So talking about AO North America. So it is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. We do not endorse nor promote the use of any product, service, or commercial entity. The equipment used in this course is for demonstration and teaching purposes only, with the intent to enhance the learning experience. So I'm sure many of you are familiar with AO. Really this started in Switzerland with treating fractures, and it has grown significantly over the years. So many of us are also probably familiar with AO Recon, so the joint replacement side of the AO family. And there's also spine and craniomaxillofacial and so on and so forth. So AO Sports is a relatively new initiative for the AO family. This started just before the pandemic. So we started saying, well, we need to talk about sports injuries too within the AO community. So we started with our first webinar. Unfortunately, obviously COVID slowed us down a little bit. In October of 2020, myself and the other co-directors, Martin Yeager and Shiyi Chen. Martin is in Freiburg, Germany, and Shiyi is in Shanghai, China. We did a webinar talking about long head biceps injuries. So if you have any questions or interest in learning more about that, please go to the AO website. That webinar is online for you. Then in November, we did rotator cuff injuries. So these are more straightforward, a little different than what we're talking about tonight. If that's interest for you, that is also online. Our third webinar from our initial series was talking about glenohumeral joint instability. So that was in December of 2020. Again, all of these are online. So use those for reference if you'd like. And we restarted our webinars again earlier this year. So had a great faculty for this, myself, Dr. Boucher, who's in Detroit, Dr. Favorito in Cincinnati, and again, you recognize Dr. Ponce. We talked about how to treat a massive rotator cuff tear. Talked about different treatment options. Again, this is also on the website if you're interested. Last one we did last month in May was myself, Dr. Scott Sigmund, who's in the Boston area, and Dr. Amir Moinfar in the Baltimore area. Talked about failed instability, doing a revision repair versus doing a distal tibial allograft. So very interesting topic, great discussion. So if you're interested, refer you to that talk as well. So this is a CME credit bearing talk. So if it's interesting for you, you'll get an email in the next couple of days. If you'd like to fill out the survey, send it back to us. That will get you credit for 1 AMA CME credit. Even if you're not looking for AMA credits, we'd also really appreciate the feedback. We do incorporate that into our webinars and try to make them better and more suited towards what you guys are looking for as participants for each webinar. So we now have courses. So this summer in Denver, Colorado, August 19th to 20th, there'll be what call a Principles of Sports Medicine course. So this is looking at the joint as an organ. So this is looking at anatomy and biomechanics, principles of arthroscopy, fixation strategies, rehabilitation protocols, So for those of you that maybe don't have a lot of experience in sports medicine or arthroscopic surgery, this may be a really good place for you to start, get some of those basic skills down and understand some of the principles of sports medicine and arthroscopic surgery. And then later on, come back to us for some of the more advanced courses that we're putting on. So this course is chaired by Dr. Jim Stannard. He's at the University of Missouri, and Dr. Seth Sherman, who is at Stanford. We're also happy to announce we have a shoulder course. This will be in Boston this fall, so September 24th to 25th. This will be alongside the OSET course, which I think many of you are familiar with. So the Saturday course will be alongside OSET, and then we'll take a trip to Raynham to a lab where we'll do on-hand wet lab, practicing some of the techniques and surgeries that we learn about. So this is chaired by myself and then Dr. Jaeger. He is out of Freiburg, Germany. So how it's set up on day one, this is what I really think makes this course unique and different from a lot of the other courses that are out there. We set this up as a small group discussion. So we're going to have individual tables. We'll have 6 participants and 2 faculty, and we'll be going this case-based clinical discussion. So kind of like tonight, we've got a case. Let's talk about the case, what's interesting, what's not interesting, what we would do, how we would do it, and then talk about glenohumeral joint instability, slap tears and biceps injuries, rotator cuff tears, and then we'll have time to talk about open surgeries as well. On day 2, again, jump on the bus. We head down to Raynham. We've got a hands-on cadaveric lab. So we have multiple stations, and we'll have faculty working at each station. So this is a chance for you to actually practice the techniques that we're talking about on the first day. So we'll be doing Bankart repairs, slap repairs, any kind of biceps treatments you want to do, arthroscopic rotator cuff repairs, and then we'll have the opportunity to do open Latarjets, tendon transfers. We have full torsos that are available for that lab. So looking at anatomy, anything you want to do, you've got the day to do it on day 2. So why should you attend? Again, small group discussions with international thought leaders in shoulder surgery, hands-on cadaveric lab to help with your skills, additional time for open procedures and dissections to kind of get more comfortable with the anatomy. And it is a CME bearing event. So we talked about that already. So Zoom etiquette, keep your microphones and cameras off. We talked about the Q&A box, and Dr. Ponce will be handling those questions for us. So overview, this webinar is aimed to discuss and identify approaches to managing a patient with a failed rotator cuff repair. Participants will gain a better understanding of the process from revision repair to subacromial balloon spacer. The case presentations will demonstrate a better understanding of why the rotator cuff repair had failed, understanding the options in managing the situation both surgically and non-surgically, and develop the ability to create and execute an appropriate surgical plan. So our learning objectives, we want you to be able, after this, to recognize factors contributing to a failed rotator cuff repair, identify treatment options when managing a failed rotator cuff repair, and be able to create and execute an appropriate surgical plan. So we're into the introduction right now. I'll turn it over to Dr. Weinstein in a minute. He'll do his first case. Then we'll have time for question and answer and discussion while we're flipping over. I'll do the second case, and then again, we'll have more time at the end, and we'll wrap it up right around 9 o'clock. So Dave, if you're ready, I will stop sharing and you can jump on.
Thanks, Eamon. Give me just a second here. We're having a thunderstorm and having some unstable internet, but I think, can you hear me okay?
Yeah, you look great.
Okay, well, thank you. Give me a
yeah, well, and we see you well.
All right, there we go. That's the important thing here. Yeah, great. Okay, well, I'd like to thank the AO Foundation for the opportunity to present and have this discussion. I think it's a great topic with the amount of rotator cuff repairs being done. Nowadays, we certainly know that most patients do well, but not everybody does. And so there are failed rotator cuffs, and Eamon's got the hard job because he's going to talk about a super complex case. I'm going to start on the other end of the spectrum and talk about how I treat a patient that I plan on considering a repair. So I just want to get right into my case. I have a 64-year-old male. He's a construction worker. He does some physical work. He's not actually doing most of the work, but he does physical activities and he does some physical sporting stuff, plays pickleball and lifts weights on the side. He had a rotator cuff repair 5 years ago. It's done elsewhere, so I don't really have the history of what's done. It looks like it was done arthroscopically because he's got arthroscopic portals. He's been hurting for about a year. He denies any specific trauma. He's had some minor injuries and trips, falls, but nothing significant where he said, boy, I just jacked up my shoulder. He's been working on some home exercises over the last year. He's had 2 recent cortisone injections in the last 5 months. The last one was about 6 weeks ago. Both of these have given him results for some relief temporarily, but no lasting benefit at all. He reports the symptoms are slowly getting worse, and he's having difficulty performing his overhead activities. He's got a couple things in his past medical history. He is non-insulin diabetic. He's got hyperlipidemia, in which he's on some statins for. He does not smoke.
Hey, Dave, this is Brent. You mind if I ask you a real quick question?
Yeah, you bet.
Hey, so was this patient new to you, or I'm just kind of curious the timing of those 2 injections, because that's kind of a big deal we're starting to appreciate more and more.
Yeah, no, this patient was new to me. I didn't perform the injections. He was seeing, I think, his primary care, who sent him over after he failed. So no, I did not inject him. Would that give you some concerns?
Well, we did a systematic review looking at corticosteroid injections either before or after surgery. More than one close to surgery is associated with a worse outcome, higher revision surgery rate. The opposite after surgery really doesn't matter once you get healing.
Yeah, I'm, if I'm concerned about somebody having a full thickness tear and somebody who's in that category where I would consider a repair, I'm talking about revision or primary, I'm pretty hesitant to do an injection until I really have come up with a comprehensive plan. That sounds like that's similar to what your findings are with your paper.
Exactly. And at the same time, it's a race between, you're right, the construct stability and biology. So if you're headed towards surgery, why handicap yourself? So that's a really good point I thought you brought up.
Any concerns about his medical history?
Well, the diabetes is a little bit of a concern, I think, just because that's going to slow down healing. Same thing with the hyperlipidemia that's been associated with rotator cuff tears.
If he was a smoker, would that, well, let's go through and then I'll come back to that question here. Let me see if I can figure out how to advance. So his examination, he's got some mild atrophy. He does have full passive range of motion, but can't quite actively elevate overhead. He's got weakness with abduction, external rotation testing, does not have any evidence of a subscap issue on his exam, and his shoulder is stable. And then here's his radiographs right here. I don't have an outlet view, but he has a relatively flat acromion. And then here's his MRI scan. So maybe I'll just stop here and ask you guys your thoughts on this patient, Eamon and Brent.
Yeah, so I mean, obviously an active guy. He's been symptomatic for quite some time. On these MRIs, you can see on the coronal view here, T2 weighted. Clearly, he has a failed rotator cuff repair. You see retraction of the, I'm guessing looks like the supraspinatus there. It's a good 1.5 centimeters, 2 centimeters retracted, at least, kind of apex of the humeral head. The tendon quality looks questionable. We worry about tendon length and tendon quality when we start talking about trying to revise, failed rotator cuff repairs. The kind of magic numbers around 15 millimeters. So if you have 15 millimeters of good, what appears to be good quality rotator cuff tendon, that's a good prognostic factor of being able to repair and get that tendon to heal. Less than 15, you got to start worrying about the quality of the tendon and the ability to get it repaired. So this one looks okay. But the other thing we worry about, obviously, being the atrophy. And so looking on that sagittal view there, you got a nice, the Y for the scapula. So really what we're looking at is the muscle bellies for the rotator cuff. Superiorly looking at supraspinatus, then on the right, you got subscap, and on the left, you got infra and teres minor. So infra and teres minor don't look too bad. Supra is definitely a little atrophied. You got, we would call it tangent line, drawing that line across from the coracoid process to the spine of the scapula. Yeah, exactly. So this would be a positive tangent sign. Sometimes this can be a little misleading because when you have retraction of the rotator cuff, the muscle is going to look a little bit smaller. But I'd say this is some pretty legit atrophy here. Not a ton of fatty infiltration, but for me, this would be right on the borderline of, can I fix it or can I not?
This is a first polling question right here. I'm interested to hear everybody's treatment plan. So I'll let the audience fill that in if we can pull that up. So poll question number 1, how would you treat this? Left some options: single row, double row repair. Would you use a graft? with one of these repairs? What about an open repair plus or minus graft? Would anybody do an arthroscopic repair and add an SCR? And then other would be, anything else, obviously, SCR, lower trap transfer, balloon, reverse. So we'll give it about 10, 15 seconds. I know you guys can't vote on this, but so let's let the audience pull it first, and we'll talk about it, and I'll get your guys' thoughts on it.
Hey, Dave, while the audience is giving their thoughts, go back to those radiographs and what are the key features you're looking at on those radiographs that you say, maybe there's something else going on here before you get the MRI, or, hey, maybe I should get an MRI earlier, or no, let's just wait and inject until the cows come home and let's look to do a reverse because he's 65.
So I don't know if I can flip back right now, if that'll interfere with the poll.
Good point.
So I'll just hold on that, but to answer your question, what I'm going to look at is, it looks like here's the answers. I'll come back to that in just a second. So,
Sure.
It's interesting because there is no majority vote here. Can you guys see this? Okay.
Yes.
It looks like single row repair with graft is the highest. That's about a third. Double row with graft, 10%. So it looks like the audience says a third would do a single row with graft. 25% would do an open repair with graft, and then in third place is double row repair without a graft. Interesting, nobody has other, and I think that at least in my mind makes sense. So that's interesting. Single row with graft would be the least top choice. What do you guys think?
Yeah, for me, a lot of it has to do with what you see intraoperatively. I do think, I think it's worth giving this guy a chance to try and fix this, because without a lot of arthritic changes in the glenohumeral joint, I wouldn't rush him off to an arthroplasty. Without a ton of atrophy, particularly in the infra, that makes me more worried about function afterwards. So not seeing a lot of atrophy in the infra makes me a little bit more interested in trying to fix this. I'll be honest with you, if you get a lot of nice tendon excursion, I got no problem doing a double row repair. If you feel like the tendon quality is of high quality, I'm kind of plus minus on the graft.
Okay.
There are some options that they are really nice for adding some collagen that aren't very difficult to do if you're on the fence about the quality of the tendon. If I'm not getting a lot of excursion, then I'm just doing a single row. I kind of do those simple stitches and try and just get the tendon back down to the greater tuberosity without a ton of tension on it.
Brent, I'm going to ask your opinion in just a second, but I'm going to give you guys some more information. Just what Eamon said, he'd make a decision when he looks at this. So here's a quick video on the what it looked like on the initial scope after bursectomy and some gentle mobilization. So this is viewing from a posterior lateral portal. There's a tendon, there's some old suture material in there. Here's a tendon, here's grasping it and bringing it down. So so the next polling question would be this. Does that change anybody's mind? So if you want to fill that out. So same options, now that you had a chance to see with some more information, that's what it looked like arthroscopically. And I'm just curious to see whether that changes anybody's opinion about what they would do to fix this.
Well, I'll tell you, the tendon looked pretty mobile. So that was really encouraging. Based on the MRI slices you showed, I was a little skeptical about what it looked like when you got in there. But it looked like you're able to really get that tendon back down to the footprint of the rotator cuff pretty nicely.
I was also a little skeptical whether or not a rotator cuff repair was actually done because I didn't see any anchor tracks. So I was glad to see sutures.
Yeah, I only showed you, I didn't put the whole MRI scan. You can see some anchors on the other views. I noticed when I put those x-rays up, I chose ones that, those sections on the MRI scan that didn't show the anchors in there, but you're right. It does look like that. So, it changed it a little bit. Look, having looked at the audience participation, people, there's a less opportunity, or at least thought of doing an open repair. I think there's a higher looking at it that kind of goes back to what you said, Amy, that Eamon, if you could get it back down, you would consider doing a arthroscopic double row. Still single row with graft is the #1 choice here. Brent, I didn't get your opinion on this. What's your thoughts?
Yeah, no, I liked what Anna was saying early on with either the idea of a single row if there's a lot of tension, or double row if there's not much tension. Biomechanically, the double row is stronger, but the clinical results both are good. I think for the larger tears, there's some belief that the double row makes more sense. And I don't mind. I like the idea of giving it the best biomechanics as time zero as possible. So my go-to would be a double row if at all possible. And I'm also comfortable medializing the footprint just a little bit to take some of the tension off, if that would also help get the double row repair. There's been 2 studies that talk about you can medialize our articular surface medial about a centimeter before you really have to worry about changing the excursion and the range of motion of the shoulder.
Do you do that, Brent, when you do a double row, or is that your go-to when you can't get it all the way over with a single row?
Well, I think for me, the key thing is a tension-free repair. And so if I think I can get a double row and medialize a couple millimeters, 5 millimeters, I'll do that also. Because I think the more biology, the more surface area contact, knowing that these are hard to heal, especially in somebody who's had a couple injections, I want to tilt the odds in my favor as much as possible to give them a robust repair, have as much biology with the bleeding bone as possible. I'll do a double row if at all possible.
So I think it's interesting. Somebody put arthroscopic repair with SCR. So there's a paper out of Australia that looked at the results of doing massive cuff tears with just straight rotator cuff repair versus doing an SCR reinforcement and then laying the rotator cuff repair over that. Do you guys have any experience with that?
I don't.
No, I don't.
Yeah, I don't either. I don't know how the rotator cuff would heal if you have the patch underneath it. So I'm just curious about that. All right. Well, just to move forward, because again, I think I'm interested to hear your case, Eamon. So here's what my plan was to do an arthroscopic revision rotator cuff repair. I like to do a double row repair. I agree with you, Brent. It's totally, can you get a tension-free repair, or at least a minimal tension on your repair? I like to use self-tensioning sutures if possible. And for tissue with poor quality, the patient's at an age where I think he can heal this. He's 64. I think he's the type of guy who needs every opportunity to try to heal this, because I don't think he's an ideal candidate for a reverse or other options. I would use some type of augmentation in this case. I would choose to use a human dermal allograft to add some more collagen to the repair. So I'm going to go through my repair procedure right here, and then happy to comment afterwards and discuss it. So this is viewing through a posterior lateral portal within a bursectomy. I've taken the rotator cuff that was stuck up to the bursa and the undersurface of the chromium and mobilized it. I've released any scar between the posterior superior glenoid and the rotator cuff immediately to mobilize as much as I can. He previously had a biceps tenodesis and his subscap was intact. So, so I've got it mobilized. As you can see, there's a little bit of pull on it, but not a significant amount of tension. You can see the tissue isn't completely healthy, but there is tissue there. You can see that he has some anchors. This may have been why he failed. You can see how medially this suture is, and I don't know if that's just stuck in the bursa and pulled out, or that's where it was put. I like to remove all the foreign body debris and take out all the old sutures if possible. Also believe in trying to get as good biology for healing. So I always perform a debridement of the footprint to get good healing tissue. If I'm not seeing a lot of bleeding, I'll do a microfracture and use a small microfracture to get some more marrow vent holes in there. And just going through that, so I have a nice pattern. And then I start with my first anchor, and this is a double row construct. So that's my anterior medial. I like to use this dual threaded biocomposite suture anchor. This anchor has a self-tensioning strand of tape and a strand of number 2 suture. A lot of different ways to pass. I'm using espresso type for passing right here. And I think this is one of the keys is where you pass your medial row. I think one of the concerns we always have with a medial row fixation is the possibility of getting a type 2 failure. So I want to make sure I'm lateral. Here's the musculotendinous junction. I want to make sure I'm lateral to that, because I think that's where you get your over-tensioning and you run the risk of getting failure here. So I'm using a suture passer to pass my tape, and I'm just pulling it out at anterior portal. In this case, I'm going to grab, because I'm not using a cannula, so I don't get a suture, a soft tissue bridge. I'm grabbing the tape first, and I'll pull that through. And then I'm going to repeat it more medially because this is a pretty wide tear. And now I'm going to just pass the two sutures, number 2 sutures that come. I'm staying lateral to the musculotendinous junction, just repeating the same thing. And this time I'm pulling my number 2 sutures through.
So David, tell us a little bit about the width of how close you want your sutures and how deep you want your bites.
Well, I'm trying to get 15 to 18 millimeters. I think the most important thing is making sure you don't go too medially. So I'm trying to stay 3 millimeters, 2 to 4 millimeters lateral to the musculotendinous junction. And I'm trying to spread out my sutures 5 to 6 millimeters. And I'm gauging that somewhat on the size of the tear. If the technique I'm using, if I didn't have such a wide tear, I would have pulled all 4 sutures through the first pass and saved myself a little bit. I want to spread out the forces here, and I'll show that a little bit better here in just a second. So now I'm putting my second anchor, my posterior medial anchor in, and just doing the same thing, creating my drill hole, putting my anchor in, just off the medial aspect of the footprint. I'm going to pass it this time with a straight passer. And this is something you often see with revision surgery. You can see that there's a rent in the tissue right here. So I have tissue medially, right up in here. I have tissue laterally, but I have a hole in it. So for the time being, I'm just going to ignore that. And this is the type of stuff that often you'll see with a revision that makes it more complex. And this is also the type of stuff, to me, why I think using, maybe for this patient, a graft augmentation makes sense. So I'm going to pass my tape sutures the same way. I'm staying lateral to the musculotendinous junction right there, 2 or 3 millimeters. I'm passing it with that. I'm using a pull suture. It just makes it a little bit easier to pass tape. And so I'm using this to shuttle my sutures. And now I'm pulling the tape through. And then I'm just going to repeat the same thing and graft tissue and pass my number 2 sutures. So now I'm going to have a construct here where I have 2 tapes, anterior and posteriorly, and in the middle here I have 2 number 2 sutures that I can use as a pulley. And so now I have this rent right here in the tissue, and I'm just going to use some number 2 sutures and do a side-to-side repair to try to get some tissue opposition. So when I lay the graft over it, I have tissue, native tissue underneath it. And so I'm just going to skip the mechanics of doing that. But now I've tied a couple sutures in there, right there, of number 2 sutures. So I have my 4 sutures right here. I have 2 tapes and 2 double-stranded sutures. And I can just grab a limb from each one of these and just tie these outside in the cannula. And this makes it real simple. So I'm tying 1 knot outside, and I'm just using a pulley and pulling both limbs, and now I'm suturing it down. And I'm using this to tie off my medial fixation, because I do believe having some tied knots medially gives you better fixation. If the tissue is of poor quality, I probably wouldn't consider doing this part, or I would use a single row construct. But I think he's got, at least medially in this area, some pretty good tissue. I'm going to grab the second limb of each of the sutures and tie it down. And now I have 4 limbs with the tape, the 2 I just tied, and the other tape posteriorly. And that gives me a stable contract. I have medial fixation, which I think helps biomechanically. I'm separating out the sutures. And you can see that this really holds down the joint just as what I've done, and it kind of seals off the joint. So maybe that gives you some advantage of keeping fluid from inside the joint leaking out into the footprint. There's some studies that show that the synovium fluid may obstruct healing, in at least in animal models. So maybe by sealing off the joint, this is going to give me some better biology for healing. So now I'm going to go down to the repair, and this is pretty straightforward. The same thing I might do as a primary. I'm going to grab a limb from each one. And so now I have 4 limbs. I haven't spread out to try to get a nice transosseous equivalent repair. I can use my cannula to kind of figure out where do I want to be. That's where I want to put my anchor. That's going to come down nicely. Now I want to augment this with graft. And as Eamon said, there's a lot of graft options you can use. I like to use this human dermal allograft because it's very simple. I'm not looking for increased mechanical strength because it's questionable whether grafts will give you that. There may be some advantage at time zero, but I don't believe most of these grafts are really going to give you any structural integrity. I want to make it simple and easy. And with this graft I'm using, I can build my own graft, and you just slide these little tags of human dermal allograft over the sutures, and I can lay them down where I want, and you can see it's pretty easy right here. It literally takes 30 seconds to pass it through the cannula, and you can see it coming into the joint. And then I can just individually start passing down. I can put as many as I want. So I feel like his posterior aspect where that rent was is the area of most compromised tissue. So this is where I'm going to lay my graft down. I'm using 3 of them right here. And then I'm going to put a lateral anchor in. Again, this is one that I can tension each suture individually, pull them down, it's tensioning the graft over as well. And then once I'm happy with the tensioning of each suture, I'm getting that where I want to be. Okay, I like that. I've laid the graft down. There's my 4th suture, the tape, and then I can just screw this in. So now I have my posterior lateral row. I'm just going to repeat the same thing with my anterior. Here's where I want to put it. I kind of eyeball it with my cannula. I'm going to put a little bit more collagen in my repair. So I'm going to pass one more of the graft. So now I'm kind of constructing where I feel like the weakness is, and that's covering up the previous area. I'm just laying down my 2nd suture. So now I have a 4 anchor construct, transosseous equivalent, which I think biomechanically is the strongest, and you can see where the graft is. So this was the area underneath here where that rent was. This was the area I think of most compromised tissue, and I think I'm hopefully adding some biology to help it to heal. You can see a very stable construct with this. And then if I look interarticularly just to see what it looks like viewing from the joint here, you can see again this is stable with some gentle internal external rotation. You can see that the footprint is nicely right down, laid down just off the articular margin. So again, I would consider this an easy repair in the sense that the patient had relatively good tissue, and he had an ability to mobilize it and have a low tension repair. So that was my presentation, and happy to start a discussion on this. Any thoughts you guys would do differently? Again, this is pretty straightforward.
Dave, I always love watching your videos because you make a very complicated and technically challenging case look so easy. It makes me want to go out and fix a couple of these myself. No, very nice. So a couple of things I was thinking. So one is a lot of times when I'm approaching a failed rotator cuff repair, I try to think to myself, what went wrong? Was it a technical, was it biological, like what happened? So with this guy, after you saw him, you saw his images, you saw intraoperatively, we saw the sutures hanging out in the tendon. What were your thoughts as to maybe why the cuff repair failed?
Well, that's a great question because he was asymptomatic or minimally symptomatic for 4 years. Didn't have any other trauma, so I'm not sure the exact etiology of it. I think he probably didn't have complete healing originally, and just over time he developed some degenerative tearing, and eventually it tore fully, and just as it started to progress he became symptomatic. That's what I think probably most likely happened. And I don't know if you got some pullout. You could see some suture debris real medially, and you could see that there was a hole, so maybe you had some partial pullout of the sutures through the tissue on there. He also has some risk. We do know diabetics have a higher risk of failure. The hyperlipidemia, I think, has been shown to be a risk factor as well. Age, he's really in an age where he should heal this. I mean, he's under 70, and so he's not a smoker, which I think is a huge risk for associated failure.
Yeah.
Do you have thoughts, Larry?
It was interesting seeing the sutures still in the tendon, because a lot of times when I see the failed cuffs, usually what I'm seeing is tendon floating up and then the sutures underneath, because obviously one of the most common cause for failure in a rotator cuff repair is that suture tendon interface. And so seeing that, seeing the suture still in there makes me wonder if, the knots were secure or if there was some suture malfunction at the anchor. But regardless, I think it was nice too with your technique. You're able to do those side-to-side sutures, as you said, seal off the joint, but then also those function, you think, as a bit of a ripstop even.
I think that's part of the help for that. And again,
Yeah.
I don't know, again, I don't know why the failure is. A lot of the risk factors like high fatty infiltration he didn't have. The critical shoulder angle. I don't know. Do you put a lot of stock in that? Do you look at that before surgery? I didn't show an outlet or.
I don't know, Brett. What do you think about that? You're the researcher.
So that was I was getting ready to ask you that question. What was your take, knowing that it's a failed? There has been some literature, you're right, and it's pretty controversial. So that kind of goes into the question about increasing the biology. Would you do an acromioplasty on this guy a second time? Would you try to get extra bleeding in the joint in addition to that little crimson duvet that you did? Tell us a little bit more, maybe some of your other tricks that you might consider doing or not doing on a revision versus a primary, trying to help speed the healing.
Yeah, I think the graft to me is the one thing. I don't use a lot of grafts in primary care cases. One of my indications is revision surgery. And again, I wouldn't put a graft. If that patient was 74, I wouldn't have done a double row. I probably would have done a single row. At that point, you're trying to get pain relief and you probably accept it's not going to heal. But this is a guy at 64 that should be able to heal this. So if I couldn't have got it all the way over lateral, I would have medialized him and done like the SCOE technique of doing crimson duvet with microfracture behind. I'm a minimalist on the acromioplasty. I usually don't do much of an acromioplasty, just try to make it flat if there's a prominence on there. I try to preserve the CA ligament, especially if he fails, so he doesn't get anterior superior escape. And then again, different types of grafts.
So do you ever do a chamfering of the lateral acromion for the critical shoulder angle, or you just say that's too much voodoo, I don't have the evidence yet?
I don't know how to assess that enough to know whether we're doing okay for that. If there's an obvious prominence that's hanging down, if there's a bone spur, if I can see something, that mechanically is rubbing on it, but I don't know enough to know. I mean, what are your thoughts?
No, I agree with you wholeheartedly. If something's there, or if it's pretty obvious that they have such a high angle, that I might try something, but those are the ones that almost have to slap me in the face and say, hey, look at me, this is different.
Yeah.
So a question came up about, do you have a cutoff of age to perform a primary cuff repair?
I personally don't chronologically. I do biologically. So if I have a patient that's, well, for example, if I had an 80-year-old patient that's extremely active, has a significant amount of hair, and a very healthy cuff that I think could heal, but he's got a 1 or 2 centimeter tear, I would fix that. I think if nothing else, you can give him pain relief. On the other hand, if I had a 65-year-old that has, diabetic, smoker, poor biology, failed rotator cuff, I'm going to probably think of something other than doing a primary repair. I don't know if you guys think of that differently.
Yeah, the only thing I do is I'll slow play them a little bit more if they're over 70.
Yeah.
And I'm a little bit more aggressive in saying, hey, let's give this 6 weeks, and assuming it's not a traumatic.
Right.
If it's an acute traumatic tear, for me, that's a different situation altogether. But a chronic degenerative, no trauma, this is hurting me for the last 5 years, I'd put them in therapy for 6 weeks and just see if they're making progress. And if they are, I would keep with the therapy. If at 6 weeks they're not making progress in therapy, then that's when I would offer them a repair again. But I do exactly the same, and that's a good point, Dave. It's like it's not so much the number; it's the patient. And if you think it's a fixable tear, then I would fix it.
You live in the pickleball center of the country.
I love pickleball.
And so you all see these older patients in their late 70s that love playing that have shoulder problems that may have a very fixable tear, or again, I think in that age, even if it doesn't heal completely, you can get pain relief and make that patient happy. So I don't, if you're getting into the mid 80s and, maybe at some point a reverse is going to make more sense. I look at the patient's biology. Can they heal it or not? And what are you trying to achieve?
Exactly. So All right. You guys keep talking. I'm going to switch over on my talk.
Yeah. Sure thing. So Dave, you said this patient's a revision. They're not too old. How do you modify, or do you modify the physical therapy or the rehab post-operatively?
What we're talking about risk factors for failure of the rotator cuff repair, primary repairs. I think that for large tears, there is a risk of early, I mean, I believe in early mobilization, but I still think you need to protect them. And so I would probably slow this guy's post-op rehab down. I would keep him in the sling for 6 weeks. I would start passive motion right away. But I would hold off on active motion for 6 weeks. I would not begin really any overhead strengthening for 3 months. And so I would put him on my slowest protocol that I have when I start physical therapy.
So one more question that came up before Amon, you get going. Rohit is asking about, will mutilating the footprint change the biomechanics and functional outcome? It really does get back to a tension-free repair. Too much tension, you're actually going to get the sutures just tearing through the tendon, which is the #1 cause of failure mechanism. But if you only do it less than a centimeter or less, there's been 2 studies that does not change the range of motion significantly, therefore the biomechanics. And so that really is a good question. And with that, I think we'll go to our next and final presentation that Aman is going to talk about, a 63-year-old. Aman, the floor is yours.
Perfect. Thank you, guys. All right. So a similar age group as Dave's patient, had about 6 months of history of left shoulder pain. It's pretty bad. It's about a 7. Doesn't recall any injury. He states he had a prior rotator cuff repair. He did have arthroscopic portals, but overall, he's a pretty poor historian and doesn't really know what they did or how they did it. And of course, he comes in with no operative note of his previous surgery, but said it happened about 5 or 6 years ago. So Brent, we talked about critical shoulder angle. What do you think about these x-rays?
Wow. I mean, that looks like it's kissing it. It's reaching down from the hand of God, touching the superior aspect of the humeral head. So I don't know if it necessarily has a really large critical shoulder angle, but it just has a really downward sloping, a lateral acromion.
Yeah.
When I think of a really large critical shoulder angle, I'm thinking the end of the acromion is near the tuberosity, way out there, which makes sense that when they abduct and they raise their arms up, it just makes sense biomechanically that they're going to be hitting and irritating the rotator cuff. It almost looks like the lateral edge of the acromion is just wanting to dig in like a ice pick into the footprint.
Yeah, that's a good point. Yeah. And we obviously can see a little bit of proximal humeral migration, on that x-ray. Obviously we're concerned about his rotator cuff. So on exam, he's pseudoparalytic, forward flexion actively to 90. I could get him about 130 passively before pain became an issue. He had good external rotation at the side, so about 60. He was weak supraspinatus, 4+, infraspinatus 5-. Subscap looked fine. He did not have any external rotation lag. So we could bring him out 60 degrees. He could hold it there, no problem, and no hornblower sign. So we got our MRI. Dave, why don't you take a shot at these?
Yeah, so a little bit different than the one I just presented. On the coronal view, you can clearly see that he has a massive rotator cuff tear. And you mentioned some of the findings for successful repair. One of them is how far the rotator cuff is retracted. This is retracted to at least the glenoid, maybe even medially, and that's a poor prognostic sign for a primary repair. We also talked about tendon length being 15 millimeters or more as a positive factor for repair. I don't even see any tendon left. I mean, I guess that stump right there. And then you can see on the sagittal view, significant atrophy. There's fatty replacement. It's got when you look at the tangent line, you can see it's well below that. On the positive side, his subscap's intact. I think that's critical for an outcome for whatever you're going to do for him. And his infraspinatus, at least part of it is intact. When you're looking at the axial view, it looks like on the sagittal that he has some fatty atrophy and he's getting some fatty infiltration as well, but part of it at least is intact, as is teres minor. And then also, and I don't think an MRI scan is a good guide for superior migration of the humeral head because you're lying flat. But Brent had asked about radiographic findings before, and this isn't radiographs obviously, but when they start to migrate up like that, that's a poor prognostic sign for a primary repair. So I think this is an irreparable supra and probably anterior portion of the infraspinatus tendon.
Yeah, definitely. And that's a really good point about the proximal humeral migration, because we'll see that on an MRI, but of course they're supine in the scanner. And the initial studies talking about that acromohumeral space being a poor prognostic factor for rotator cuff repair, that was defined on an upright AP view of
Yes.
the shoulder. So when you're talking about proximal humeral migration, you always want to make sure you're talking about an upright AP of the shoulder as it relates to the repairability of that tendon. All right, so Chris, if you want to put up the question, so let's see what does the audience want to do for the 63-year-old, very nice gentleman who's got a very sore shoulder. So unfortunately, I can't see what you guys are seeing. So
Even I'm looking at your options, which you obviously know what you
Yeah.
had. You didn't put SCR in there.
I did not. You're correct.
No. Do you have a thought on SCR? Or I guess let's see what the panel comes up with first, and I'll tell you what the results are once they come up.
Perfect. Yeah. So I
Um,
mean, is this someone that you think so you think SCR should have been on my list?
Well, yes.
Yeah.
I
Fair.
mean, I think it's an option.
Yeah.
And has he? I don't remember what you said about treatment. Has he had any treatment?
Nothing.
Nothing. Okay.
Not since his surgery. Yeah.
Okay,
So
nothing.
he came in 6 months. It's been hurting him. No trauma. No treatments.
So that raises a really interesting question. 6 months, but yet he had his surgery 5 or 6 years ago. What do you think happened 6 months ago?
I don't know. He's a really poor historian. So it was hard to get any information out of him. Nothing really happened, usual stuff. I really don't have a good answer, but my gut's telling me that his MRI has looked like this for a while.
I think so. I'm going to give you the results right here. Even steroid and PT are tied with a subacromial balloon at 27%. So
Okay.
steroid PT 27%, subacromial balloon 27%. Number 3 would be rotator cuff repair.
Okay, so that's fun. So we've got a tie between operative and non-operative treatments.
Yes.
So steroid injection PT, Brent, you think there's any role for that in this patient?
I do. Partly because then what's your next treatment is what I'm thinking about. If you're thinking of something biologic, like, hey, I'm looking to do a repair primarily or a partial repair, or I'm thinking about doing like a lower trapezius tendon transfer, then I may be saying, maybe let's don't do an injection. But if you're thinking, I'm going to do something definitive, like a reverse, I don't think there's a downside with an injection because you're not worried about changing the biologic environment. Same thing with the balloon or an SCR. So I would have no problem based on what the patient would give me.
Yeah, that's a good point. And a lot of this, as we've all alluded to, is, really having that engaged patient and having that shared decision model and talking about all the different options. And I agree with you. If you're thinking you're going to try and fix something, then you want to stay away from the steroid injection. But if this is something you say, listen, we're going to try this. If it doesn't work, then these are our non-repair options down the road. Then that would be a perfectly reasonable thing to do. Dave, any role for scope debridement? We're going to ignore the tear and just go in and debride them. Biceps looked okay. I mean, I guess you could do a biceps tenodesis here if you felt inclined, but any role for not doing a scope with no repair?
Well, I don't think there's anything here to repair. I mean, maybe you can pull some of the infraspinatus up. I think he clearly has no supraspinatus left. So if you're going to scope them, it's not with intention of doing a partial repair because I don't think there's anything repairable. I don't find, at least in my experience in reviewing the literature, that there's a real high advantage of doing a scope debridement. I think you're really probably wasting the patient's time. I would certainly start with a steroid injection in PT because I think, there's a minuscule risk of an infection. Other than that, as long as you're not going to do something definitive for 3 months, I don't see any downside. There's some pretty good literature that supports that 70% of patients will do okay with that approach. Now, if this guy's super active, probably not, or maybe not, but I think there is definitely a role depending on the patient's activity level and so on for non-operative management to start. Now, let's assume that fails. I wouldn't do a scope debridement.
Okay, great. I think we've all agreed the cuff is largely not repairable. Maybe you might get a little partial, but that's really not going to be definitive treatment for him. So subacromial balloon, Dave, any experience?
Only seeing 2 failed balloons in the last, since it became, FDA approved in the last 3 months. I think it's candidate picks, inappropriate candidates for these, but I don't have enough experience to know. I mean, I hope that turns out to be a viable solution, because it's a great thing if you can buy some time or stabilize this guy's shoulder. There was a great point made. Why did something happen 6 months ago? So my assumption is he's had a chronic tear for many years, but he had stable mechanics, and then something tore enough or inflamed his shoulder enough that he's not stable anymore. So maybe if you can reset that, you could get him back how he was a year ago, which probably had the same looking MRI scan.
Yeah, that's a great point. So lower trap transfer, any takers, Brent?
So given that he's a poor historian, I'm a little bit concerned about how compliant he would be, and given the biology a chance to heal, especially if he's a one-time loser. He didn't heal the first rotator cuff repair. At least I don't think he did. So if he's a manual laborer, I don't see much arthritis, and they still can do well with some arthritis. But at the same time, I have no problem doing a lower trapezius tendon transfer. But I just don't get the vibe from this guy that he's got to be manual. He's got to use it. He needs something biologic. He was doing well with probably a lousy shoulder for quite a while. Is it possible we can kind of get him back to where he was and buy him a few years and then consider just doing a reverse? That may be the simplest answer in this guy.
Yeah, exactly. Obviously, last reverse, but I think we're all kind of on the same page. Without significant glenohumeral joint arthritis, that we're going to shy away from the reverse in this guy at this time. So interrupt findings: articular cartilage is pristine. There on the right, you can see a subscap that was totally intact. Biceps was fine. Here's looking from that posterior superior portal, sorry, posterior lateral portal. You can see I'm grasping his supra as compared to Dave's case. You can see the tissue quality was terrible. And that was as far as I could pull it. You know, basically it was medialized to glenoid, medial to glenoid, and I could barely get it to the joint line. So there was absolutely no chance, even if you're going to medialize the, you know, like Brent was talking about, there's no way to fix that supra. Infra, there was something there. So you can see here on the right, there was some decent tendon quality there, and it was mobilizable to the greater tuberosity. So to Brent's question earlier, what happened 6 months ago? You know, maybe he had a balanced shoulder, so his force couple was balanced between his posterior and anterior cuff. Maybe the posterior cuff just tore a little bit more, and that threw him out. Destroyed his force couple, and now threw him into a bad place. So this is a case about a balloon. So that's what I did. So I started with a posterior repair. So I thought I could get the posterior cuff reestablished. So I figured if nothing else, if I can get his posterior cuff to heal, rebalance the shoulder, and then use the balloon to better center the humeral head, I can give him a head start on his PT and give him the best possible chance of restoring function to his shoulder. So this is after the partial repair, obviously viewing from that posterior lateral portal, you can see the longan biceps tendon there. And so this is before, and this is, as on the left, this is the balloon. So that comes through your lateral portal. There's a way to measure it. You know, you go about 1 centimeter medial to the glenoid, and you measure it to the lateral aspect of the greater tuberosity, and that gives you the size of the balloon. And then based on the size, there's a certain amount of fluid that you inject. You over inject the balloon to start with, and then you pull a little bit out so that it's not. So basically by over injecting it, you allow the balloon to fully spread out in the subacromial space. And then by pulling a little fluid out, you're making sure that's not over tensioned. So on the,
Hey, Mon, can tell us once again how you made your measurement, and did you include your repair in that measurement, or you excluded the repair in your measurement?
Yeah, so the repair is excluded. So that was sort of a separate thing. I saw a cuff that I thought I could repair, and I figured, you know, whether or not the balloon will actually help, if I can at least get the posterior cuff to heal, then I balance his shoulder and I give him the best chance for a long-term outcome, depending on how well the balloon helps him. As far as measuring it, there's a guide that they give you. And so you measure it. So you go about 1 centimeter medial to the glenoid and then to the lateral aspect of the greater tuberosity. And that just helps you judge the size of the balloon. So it's a medial to lateral measurement that gives you the size. And it's a really nice little deployment. You go right through that mid-lateral portal. And then as it comes rolled up, like you see there on the left, and as you inject the saline, sterile saline, so I'm holding the guide, it's like a long cylinder, and then my assistant is injecting the saline. And then once it's completely injected, then she's pulling back a little bit. And so on the right here, you can see this is looking, same view. Now we're actually looking through the balloon. So it's interesting, you can actually look into the joint through the balloon once it's fully inflated. And so at that point, what I like to do, I don't have the video, unfortunately, but I'll take the shoulder through a range of motion. and just make sure that the balloon is stable and not, and obviously not moving around, and that it is helping depress the humeral head. So this is the view from the lateral portal there on the left. So again, looking through the balloon, it's stable, and you can see it's fully engulfing the subacromial space there. So I hadn't come back 2 weeks for his first post-op, so got an X-ray, and when we want to compare it to our pre-op on the left, for what it's worth, and you guys tell me if I'm crazy, they look like fairly comparable views, and I feel like there is some recentering of the humeral head, some reduction of that proximal humeral migration. There's some more space, at the acromial space.
I agree too. Yeah.
I didn't do a subacromial decompression. I did not, do anything to a CA ligament, because again, as Dave pointed out earlier, I'm worried about anterior superior escape. So left that alone. But at least on these X-rays, it looks like the balloon has done what it's supposed to do by recentering the humeral head. So my protocol: sling for 6 weeks. Again, this guy's a partial cuff, so I'm treating him as such. If I didn't do a partial cuff, then I would mobilize them with active range of motion at 2 weeks. So active range of motion for him is going to begin at 6 weeks, light strengthening at 10 to 12. So for me, this is a typical rotator cuff protocol. Again, because I did the partial cuff, would really speed this up a lot if he didn't have the partial cuff. So follow-up 6 weeks, pain was improved, still didn't have great function. At 3 months, pain continued to improve, started getting more function. At 6 months, pain wasn't really, it was more of a, he says it's not pain, it's an ache. Function improved, so he was 130 in forward flexion, external rotation to the side, 60, he was still weak, but it's predictable. But I do think that by recentering the humeral head, that he was able to, again, achieve range of motion above the horizontal. So we look at some of the study. Yeah.
Was the patient happy?
Patient was happy. Yep.
Okay.
He was happy. He was happy to do it again. So a little bit of back history on him as well. So I, again, shared decision-making model. I went through all the treatment options, and he said, I'm absolutely not doing a replacement. And I told him, well, I can't fix your cuff, but this is a compromise. And he did not want an injection because he had friends who had injections and it hurt and it made him worse. And so he was out on the injection. He just wanted surgery, and this was sort of this became the compromise for this particular patient. But yeah, no, he was happy with it at the end.
I think that's I think that's a nice job, because I think for him, as Brent said, I think you're trying to find a stopgap to get him to the point where he has his reverse.
Yeah,
I think that's going to be the end point probably for this guy at some point. And if you can get him some time that, few years or farther time, I think you help them. For me, this would be an SCR probably.
Okay.
You got the posterior cuff fixed. That looked good. That alone might help him. I'd probably put an SCR in there. I heard this term midterm adapter, and I've kind of adopted that for a lot of things. And I'm waiting personally to see a little bit more data. One thing I'd ask you though is, I've noticed some of the guys in our town are doing balloon, but they're having trouble getting them approved. Did you have issues, or how did you get that approved by your hospitals?
Yeah, so I did this in my surgery center.
Okay.
So there we have a little bit more latitude as far as what we're doing. So there's obviously no code for the balloon spacer. So it has a lot to do with what else you think you're going to be able to do during the surgery to get, to repair it. So for this, he was a rotator cuff repair. So for the center, being able to repair the rotator cuff, that made the finances reasonable enough that they were able to take the hit on the balloon. So a lot of it's a discussion with your center. Hospitals, there's one hospital that they allow it. I don't know why, but somebody else obviously forged that battle before me. But yeah, I'd say, if you think it's something that's appropriate for your patient, talk to your materials manager, either at your ASC or at your hospital, and see if it's on contract, what they can do. But yeah, it is definitely more expensive than a couple anchors.
I've seen 2 failures I was mentioning, and both of them had irreparable substeps. What's the thought on those patients? And they were riding up, 3 months later when they came in, they were riding anterior superior, not really true escape, but they're definitely subluxed in that direction. Is that a contraindication?
So next study I'll show, actually one of Joe Aboud's studies, the patients with the repairable subscap did much better. So I think kind of like an SCR, we're balancing the shoulder, but we still need that subscap to be intact. So for me, if they had an irreparable subscap, I would not even try this because they're not going to do well. But with a intact subscap or repairable subscap, then it's worth. If everything else looks good, then it's worth trying to balloon. Yeah, but yeah, that's those irreparable subscaps. Those are problems because of that anterior superior scape. Yeah. So looking at some of the studies, this is looking at a subacromial balloon spacer versus partial repair for massive cuff. It's a prospective randomized multicenter trial. This was a presentation last year at AOSSM annual meeting. They had 93 balloons versus 91 partial tears. They looked at Western Ontario's and ASCS. They found overall non-inferior outcomes with the balloon compared to a partial rotator cuff repair at 24 months. So again, it's at least as good as a partial repair. And this is just a balloon, no repair. So then earlier this year, Joe Aboud and his group looked at the balloon spacer for massive irreparable rotator cuff tears, found that they were associated with improved functional outcomes, low revisions and complications at minimum 1-year follow-up. He had 78 patients in this group with 56 months of follow-up on average. He did have 55% of the patients were pseudoparalytic, kind of like the patient I had. Those patients that were pseudoparalytic, 55% of them regained forward flexion greater than 90 degrees. So there's an opportunity to reverse pseudoparalysis with this procedure. He noted that the best patients were over the age of 65, and those that either had an intact subscapularis or did a subscap repair. Those are correlated with better ASCS outcomes. Finally, the newest study that's out there, this was Lancet back in April. This, I believe, came out of Europe. 117 patients. This is a double-blind, multi-center randomized controlled trial. So they actually excluded any patients with osteoarthritis of the glenohumeral joint, subscap deficiency, or pseudoparalysis. So they had 61 patients in a debridement-only group, so scope debridement, versus 56 patients in a debridement and the subacromial balloon spacer. So they looked primarily at the Oxford score at 12 months, and they found that the debridement actually did better. So a lot of excitement early on. This is kind of pulled back a little bit on some of us as to what we realistically can do. Obviously there's a lot of different ways to look at this. This study is obviously not favorable for the subacromial balloon, but I think as we get more experience with the balloon, we'll better understand, sort of where the opportunity is. And like you mentioned, subscap status is very important for this. So conclusion for this, subacromial balloon spacer has been shown to be safe and effective. My patient liked it. Massive irreparable rotator cuff tears. Just gotta make sure you have the right patient, the right indication. When you're doing this, make sure you don't take down the CA ligament. Again, if you do an aggressive acromioplasty, you take down the CA ligament, you run the potential for anterior superior escape, and that patient's not gonna do well in the long term. If you can, combine it with a partial rotator cuff repair or full rotator cuff repair. There's a growing trend now in Europe that they'll actually combine this with, say, with Dave's case. So big repair, throw in the balloon on top of it, potentially help recenter the head, help with rehab postoperatively, but then maybe even give a little bit of compression at the greater tuberosity. Is this a potential use for the balloon spacer? So instead of just being a bridge option for a reverse, we're actually trying to augment our rotator cuff repair with the balloon. It can reverse pseudoparalysis in the appropriate patient. And again, subscap is critical for this procedure.
No questions came up during that time. At the same time, this would be the time, if anybody does have a question, to feel free to ask it. So it does raise the question, you talk about protecting the rotator cuff repair with the balloon after you do a repair. I guess my concern would be, are you also necrosing the repair and you're strangulating it and you're really not giving it a chance at all? So it really is just a fascinating dilemma to figure out what's going to happen down the road. And I'll let the Europeans figure that out for me.
Where does this fit in your practice? What's your patient that is the right patient for this?
Yeah. So, ideally, and I believe that the FDA clearance is actually for patients over the age of 65. And again, in Joe Aboud's study, that was the ideal patient over the age of 65 with an intact or repairable subscap. So, that's kind of a starting point. And again, for me, I really like using the shared decision-making model. And so I'll go through all the treatment options for patients. And if there's, not a lot of arthritic changes at the glenohumeral joint, we can talk about, and they don't want to do a reverse, then we can talk about other options. I am not a huge SCR guy. And so I haven't really gravitated to that procedure. For me, rather than SCR, I'm often doing the lower trapezius transfers at this point, but perfectly appropriate to try. And to be honest with you, that's probably, you're doing a lot of the same thing with the SCR as you are with this balloon. You're just helping to recenter and the humeral head and almost, the SCR actually obviously works a little bit like a tether. I mean, if you look at Mahata's study, I mean, they're using 7 millimeter thick IT band grafts. So there you go. That's your balloon. You're sticking 7 millimeters of tendon in the subacromial space. So they're all kind of achieving the same ultimate goal. The question is, what's going to have the longest outcome, of good outcome, and where these are going to go down the road. Because again, as you alluded to earlier, my feelings, a lot of these are really just bridges for the reverses in the future.
So Amon, here's the question. Tell us a little bit about your own learning curve and some of the things you do different now than you do initially.
As far as the balloon?
Correct.
Well, I've only done a handful, so I'm still definitely learning. But I'd say definitely repair what rotator cuff you can. I think the first couple I did, I probably was a little too worried about overinflating the balloon. And so really following their guidelines, I pulled out probably a little bit more fluid than I needed to, because I was worried about the balloon popping. And then I'd say just, doing a good debridement. But, from a technical standpoint, as opposed to Dave's case, which is very technically challenging, this is not hard to do. It's, measurement, you stick the balloon in there, you inflate it, and then you get out. So I guess, not that I've had this experience, but maybe if a patient that, medically is a little bit more complicated and they, might be able to take a, 45-minute to an hour procedure, but, depending on how long it takes you to do an SCR or reverse, that might be a bigger procedure that maybe the patient from a medical standpoint might not tolerate. Then this might be an option for you. But yeah, the learning curve, I think, is better understanding the patient that this is most appropriate for. And for me, that's really intact subscap, normal glenohumeral joint, and someone who wants to, doesn't want a reverse. Oh, the other thing I should say is that no matter what you do, this will not improve external rotation. So I want to see that they have active external rotation, because if they have a lag sign, then this is not going to get that back, and they're still going to be, their pain may be better, but they're not going to get that external rotation back.
I appreciate the response and excellent presentation. Thank you.
Thank you.
Great.
All right. Well, that was great. I guess if there's no other questions, I guess we can sign off at this point. Again, thanks to everybody for your attention. We hope to see you again at future webinars and hopefully even at a course. So remember the principles course in Denver in August, and then the shoulder course in Boston in September. Thanks everybody, and have a great night.